A qualitative study of the barriers and enhancers to retention and care for pregnant and postpartum women living with HIV, the EA-IeDEA Kenya PMTCT Study. Retention and care is a major challenge in the PMTCT continuum. However, the factors influencing retention from the perspectives of women who have become lost to follow-up are poorly understood. We explored these factors within an enhanced subcohort of the East Africa IDEA in Kenya. From 2018 to 2019, a purposeful sample of pregnant and postpartum women living with HIV were recruited from 5 maternal and child health clinics providing integrated HIV services in Western Kenya. Women retained in care were recruited at the facility. Women who had become lost to follow-up were recruited through community tracing. Interview transcripts were analyzed thematically using a social ecological framework we developed that was based on the PMTCT literature and the Anderson behavioral model of healthcare utilization. 41 women were interviewed. The median age was 27 years, 71% were pregnant and 29% postpartum, 46% were newly diagnosed with HIV at enrollment in antenatal clinic, and 39% had become lost to follow-up. 80% were taking first-line ART at the time they enrolled in the study. Multiple social ecological factors influencing retention for pregnant and postpartum women living with HIV were identified. For example, in the individual domain, prior PMTCT experience and desires to safeguard the infant's health enhanced retention, but were offset by perceived lack of value in PMTCT services, particularly following the infant immunization period. In the peer and family domain, male partner financial and motivational support enhanced retention, but lack of this support, either from the male partner or other family members, were barriers to retention. In the community and society domain, some women perceived social pressure to attend maternal and child health clinic, while others perceived pressure to utilize traditional birth attendants. In the healthcare environment domain, long queues and negative provider attitudes were prominent barriers. HIV-related stigma and fear of disclosure were pervasive themes that crossed multiple domains, particularly for women who had become lost to follow-up. These themes were driven by perceptions of HIV as a fatal disease and fear of partner abandonment and abuse. Both women who were retained in care and those who had become lost to follow-up perceived that integrated HIV services increased the risk of disclosure. Multiple women, both retained and lost to follow-up, also reported that long queues and excessive time at the clinic outweighed the value of the care services against competing priorities at home and in the workplace. In summary, stigma, concerns about unwanted HIV status disclosure, and poverty were prominent barriers to retention, particularly for women who had become lost to follow-up. Women who were retained in care, in contrast, expressed themes relating to healthcare service quality and efficiency that influenced their healthcare-seeking behaviors. This study illustrates the great extent to which pregnant and postpartum women living with HIV must navigate multiple, sometimes conflicting social roles, statuses, and identities related to HIV, motherhood, and social class just to maintain retention and care. Interventions to address multiple barriers simultaneously are likely to have the greatest impact given the complex nature of retention for this population. Such interventions may also need to be highly contextualized and individualized. This is a critical challenge for care programs given the current magnitude of non-retention in the PMTCT continuum in sub-Saharan Africa.